This CT scan shows the presence of a focal defect in the left side cribriform plate anteriorly, approximate the level of the bulla ethmoidalis, and shows the presence of a small protrusion seen on the MRI as well, continues with the CSF column, suggestive of a CSF leak or possibility of a meningocele on the left side. This patient has had watery rhinorrhea, more so on bending downwards for the past 1 month, and has also had 2 episodes of meningitis in the past. As you see, small defect in the cribriform plate is mostly one of the most common places in female patients to form a CSF defect that is idiopathic when leads to CSF rhinorrhea. Surgical repair is indicated so as to close this defect and create a graft and separation of the cranial cavity from the nose to avoid any communication between them. In this cisternogram, you can also see some signals in the sphenoid sinus, but that is more so on line supine, which is the same fluid tracking back towards the sphenoid sinus, but there is no continuity of this column with the intracranial space in the sphenoid. So these scans are taken both prone and supine positions to be able to ascertain surely where the defect is from, because in these patients one has to have a open eye and mind, because there couldn't be more than one defects as well, and the defect could be on both sides even if the leak is happening on one side at this time. This defect is closely seen very clearly in the left side cribriform plate. The plan here is to take this patient for surgery, do a full ethmoidectomy, anterior and posterior, and trostomy and a sphenoidotomy to identify the skull base in total in the left side, and then proceed to a middle turbinate resection to be able to not just identify the defect and the meningocele clearly, but to also create a nice and flush bone bed for our graft to be placed. Though one can also simply go for a middle turbinate resection and plugging of this defect with the fat, but generally we prefer a full ethmoidectomy so as to give us a wide area of bone for graft placement. You see, basic sphenoethmoidectomy has been completed here with the middle turbinate in place. That's how we do it to retain this as a landmark. And once we have done that, then we proceed to removing the middle turbinate, excising it flush with the skull base. In some patients, one requires drilling to make the base flush, and in some patients, one can even avoid that. A slight amount of deviated nasal septum is a common finding. One can proceed to a septoplasty if the deviation is significant and affects the vision and the instrumentation. As you see here, we can see the ethmoidectomy cavity on the left side and the enterostomy side as well. And after this, we proceed to the middle turbinate resection. As you proceed to the middle turbinate resection, you start seeing the site of leak and actively leaking CSF onto the cribriform plate region, very, very close to the septum, almost appears as if it is coming from the septum itself. And once we have resected the middle turbinate, then we use our coagulation wand to achieve hemostasis as well as ablation of the residual mucosa around the defect, as well as coagulating it so that the entire area of bone becomes bare for a graft placement. The plan here would be to use a fat plug to plug the defect, as well as using a layer of fascia lata or temporalis fascia to place on the defect site, followed by free mucosal graft from the middle turbinate. As you see here, we are along with ablating, we also use our cranial true cuts to remove the ethmoidal septations because this is very important when our fascia is applied in this area, so that it does not become overturned on itself. And doing a frontal sinusotomy to be able to see the frontal sinus also is important, because sometimes the fascia can also lead to uh, stenosis of the frontal sinus ostium, and thus leading to frontal sinusitis. So at all points, we should be very sure that we should not cause any sinus to be occluded, most importantly the sphenoid for posterior defects and the frontal sinus for the anterior defects. And now once we have isolated this defect, which we are pointing with the help of a navigator probe, you can see here it's not leaking right now because of the use of the coagulation device. Now what is left is the plugging of this using a fat plug. So the concepts of any skull-based leak, whether it is from sphenoid, ethmoid, or cribriform plate, remain the same. It is isolating the defect. It is uh, coagulating it using a coagulation device or a bipolar forceps. It is reasonably ablating the mucosa around it, making the bone flush if it is already not so, and then using an appropriate graft for the kind of defect that we see. And once we have seen that, we use the bipolars to coagulate the defect region as well as the mucosa around it. Sometimes it also happens that once you have coagulated it and the meninges are no more protruding, it might become slightly even difficult to appreciate it. So one must have appropriate landmarks ready as to where the original site of defect was if one is not using the navigation probe. In large size defects, it's easier to identify, but smaller ones sometimes are very difficult to identify once you have removed a fair amount of bone and have ablated the meningocele sac. So you see here, we take our time in using the coagulation wand generously here, because we do not want mucosa buried under our grafts, and for the graft to be uptaken nicely, we want to be very sure that we have exposed the bone and have denuded all the mucosa. Once again, we double check on the site of defect, and then we, since it's a very small defect, options are to enlarge it sometimes to create a bigger one, but sometimes if you can find it, you can also use fat to be plugged inside it and utilize the small defect to your advantage. If, however, one has to use only fascia, then the defect has to be enlarged before you can place fat inside it. Once again, we palpate the defect using a blunt instrument to double and triple check the site of actual defect before we occlude it. Now we are using a 70-degree angled endoscope camera pointing upwards, and that in our practice has been quite handy in this part of the surgery once we have done the ethmoidectomy and most of the procedure, because then even the slight deviation of septum does not bother us because we are looking upwards. So again, reiterating the defect site with the navigator probe to make sure that we are right. Sometimes in a very small defect, it gets occluded and you're not able to make out the original site. And now that we can feel the slight defect with your instrument, you keep the fat ready to be placed here. Now we use fat, and the fat has to be gradually and very slowly tucked in and pushed inside the defect. The fat must be sized appropriately. A very big fat size like you saw earlier would not go in. And then it has to be trimmed to a size that can be pushed in. One cannot use force here, and we don't ever advocate using a ball probe because it kind of pulls the fat back. So normally we use a blunt tipped elevator, a long elevator, to gently, slowly and steadily put the fat in the site of the defect before we resort to using the fascia. The only thing you want to check, double check and triple check is the fact that the fat is nicely tucked in. It's not just lying loose there, and it must be a good amount of it must have gone inside the defect and must be protruding in the intracranial cavity before we can be sure that this is well set. A slight overfilling of fat is good because we assume that some bit of it would get reabsorbed in the coming weeks or months. So just to be sure, we use a little extra fat, and if there is a little extra, we could also even trim it down with the fine scissors once we have placed the bulk of it inside the defect. And now we see that it is looks nicely set in uh, there. And on top of this, we have used a fascia graft, a small fascia graft, again not a very big one. Important is it is to see that it should be having contact with the bare bone on all sides and not mucosa, because if it is kept on the mucosa, it will not take up. So the fat must be covering the fat. The fascia must be covering the fat, and it must be on contact with the bone all around and must not be turned onto itself, because then there is a higher chance of the graft being not taken up. It's a general good idea to make sure that the uh, not a lot of fat should be protruding or exposed to the air when you use the fascia, or in some cases if the fascia appears to be slightly small or some bit of fat is protruding, you can cover the last bit of it using a free mucosal graft that we have harvested from the middle turbinate. So here we use a free mucosal graft onto the assembly of the fat and fascia. This free mucosal graft is obviously there in plenty because you've excised the middle turbinate, and also helps in early remucosalization of this region because of the presence of mucosa. So as you see, we have covered that part of it, which was where the fat was being protruded, with some fascia being in the back. That is all right. And again, we tuck it, see that there is no air or blood inside it, palpate it from all sides. And once that is done, then we can resort to using the tissue glue on this assembly.